Hello everyone, I'm Dr. Prashant, and in this presentation we will talk about the causes, diagnosis and management of tumor lysis syndrome. Tumor lysis syndrome is defined as a constellation of metabolic abnormalities that occurs as a result of the release of intracellular contents secondary to tumor cell death. Let's discuss the pathophysiology of tumor lysis syndrome. This is a schematic diagram of a blood vessel, and we will take the example of a patient with acute leukemia. When this patient receives chemotherapy, there will be lysis of the cells. Cell lysis will bring about release of intracellular contents, which include potassium, phosphate, and nucleic acids. The additional potassium so released will accumulate in the body and soon overwhelm the excretory capacity of the kidney. Similarly, the additional phosphate so released will combine with the calcium present in the serum, and this will cause a progressive decrement in the calcium levels because of combination with phosphate. The excessive nucleic acids that are released are eventually metabolized to uric acid, which causes renal dysfunction. Therefore, the steps in formation of tumor lysis syndrome include cell death in a rapidly proliferating tumor. The patient may have received chemotherapy. This results in tumor lysis a few hours or days after the start of therapy. We must note that tumor lysis may also occur spontaneously in the absence of chemotherapy. Tumor lysis causes cell death with release of intracellular contents. This causes release of potassium, which results in hyperkalemia, phosphate, which causes hyperphosphatemia, and nucleic acids, which are purines and are broken down to uric acid, causing hyperuricemia. The metabolic effects of these abnormalities include cardiac effects secondary to hyperkalemia, renal dysfunction secondary to hyperuricemia, and hyperphosphatemia would cause secondary hypocalcemia, as just discussed. These metabolic abnormalities now cause renal dysfunction, which results in fluid retention, metabolic acidosis, and hypoxia, resulting in multi-organ failure. Let's move on to the etiology and associations of tumor lysis syndrome. Malignancies associated with tumor lysis include chemosensitive myelolymphoproliferative neoplasms, acute leukemias, large bulky adenopathy seen in high-grade non-Hodgkin's lymphoma, and infrequently with solid tumors due to lower growth fractions. Other causes of tumor lysis syndrome include ionizing radiation, embolization, radiofrequency ablation, monoclonal antibody therapy, glucocorticoid therapy, and interferons. Hematopoietic stem cell transplant may also cause tumor lysis syndrome. The diagnosis of tumor lysis syndrome can be classified into laboratory TLS, which consists of having 2 or more of the following occurring within 3 days or after 7 days of chemotherapy. These include a uric acid of more than 8 milligrams per deciliter or a 25% increase, a potassium of more than 6 milliequivalents or a 25% increase, a phosphate of more than 4.5 milligrams per deciliter, and a calcium of less than 7 milligrams per deciliter or a 25% decrease. Clinical tumor lysis consists of laboratory TLS plus one of the following. These include increased serum creatinine more than 1.5 times the upper limit of normal, cardiac arrhythmias, and seizures. Let's look at the metabolic abnormalities individually. Hyperkalemia is caused due to the intracellular potassium release, and this accumulates because it exceeds the renal clearance capacity. The clinical manifestations of hyperkalemia may include electrocardiographic abnormalities, muscle cramps, weakness, and diarrhea, and the management includes aggressive hydration, exchange resins, calcium gluconate, sodium bicarbonate, dextrose and insulin infusion, and loop diuretics. We will review the management of tumor lysis at the end of this presentation. Hyperphosphatemia is caused due to intracellular phosphate release, and the accumulation rate exceeds the renal clearance capacity. Hyperphosphatemia can cause acute renal failure and secondary hypocalcemia, and it is managed with aggressive hydration and dextrose and insulin infusion. Hypocalcemia is caused due to increased phosphate and precipitation of calcium phosphate, as already discussed, and can cause muscle twitches, tetany, carpopedal spasm, and mental status change, and is managed by managing hyperphosphatemia. hyperphosphatemia. Hyperuricemia is caused because of nucleic acid breakdown and can cause acute renal failure and is managed with allopurinol, hemodialysis, and aggressive hydration. Lactic acidosis is caused because of hypovolemia and acute renal failure and manifests as acidemia and can be managed with aggressive hydration and correction of acidosis. The management strategy in tumor lysis syndrome includes monitoring of lab abnormalities, which alert physicians and guide preventive management. Aggressive hydration is the mainstay of therapy up to 3000 ml per meter square of body surface area. Aggressive treatment of hyperkalemia may be done with calcium gluconate, which antagonizes the cardiac effects of hyperkalemia, nebulization with albuterol or salbutamol, hypertonic dextrose and insulin, loop diuretics, cation exchange resins, and hemodialysis. The management of hyperphosphatemia consists of oral phosphate binders and avoidance of calcium as it promotes metastatic calcification. Treatment of hyperuricemia consists of allopurinol, rasburicase, and dialysis. Let's compare and contrast allopurinol and rasburicase as treatment modalities for hyperuricemia in tumor lysis syndrome. Allopurinol is oral and easy to use, whereas rasburicase must be given by an intravenous administration. Allopurinol has a slow onset of action and has no effect in pre-existing uric acid levels. However, rasburicase is rapid and allows start of chemotherapy without delay. Allopurinol may be ineffective in some patients, whereas rasburicase lowers the uric acid level in all patients. 1% of patients on allopurinol will have allopurinol hypersensitivity syndrome, whereas 4 to 5% of patients on rasburicase may have some degree of immunoallergic reactions. Allopurinol can interfere with the metabolism of 6-mercaptopurine, whereas rasburicase has no effect on this drug. Allopurinol does not confer an increased risk of G6PD deficiency, which rasburicase does. Allopurinol has comparable efficacy in preventing acute renal failure and the need for dialysis. Rasburicase lowers the incidence of TLS but not clinical tumor lysis. And finally, allopurinol is inexpensive, whereas rasburicase is very expensive. To conclude this presentation, we have a special point about the transport of samples of patients on rasburicase. This is a schematic diagram of a blood sample taken from a patient who has been given rasburicase. This patient also has uric acid in this blood sample, and while being transported, there might be ex vivo degradation of uric acid resulting in a fallaciously low level of uric acid. This ex vivo degradation of uric acid may be prevented by transporting the sample at 4 degrees. That's it for our presentation on tumor lysis syndrome. Thanks for watching, and we will see you in the next video.